This podcast is pre-recorded, intended for educational and informational purposes only, and should not be considered medical advice. Always seek the guidance of a qualified healthcare professional regarding any medical concerns or treatment decisions.
Hi everyone. So today I'm very delighted to be welcoming Dr. Rahul Modi. Rahul is an ENT in Mumbai. I met him last year at a conference in Amritsar, and on meeting him, the first thing I kind of got, we were on the same wavelength, although me being a dentist, him being an ENT, but we both have the same kind of mantra about breathing is vital, breathing healthily is good for your body. And today I'm really delighted to have him with me so he can share his perspectives. So, Rahul, tell us a bit about yourself so the audience can kind of understand and see how you work.
So, hi Suraj, thanks for having me here. It was lovely chatting with you in Amritsar, and it's a very exciting field, right? So, we are all very happy when we see people who think like us when we are dealing with patients and
True.
who want the best for our patients. So, regarding me, I'm a general ENT surgeon based out of Mumbai, India. And sleep has been my, I would say, passion project for more than 10 years now. And especially, sleep problems in children, which I feel, I mean, especially in the Indian scenario, that they're so overlooked that it drives me even more to create more and more awareness. So just happy to be here.
Oh, well, lovely to have you. So, when we talk about sleep in children, I'm looking very culturally speaking, because in the UK, it's kind of they put their children to sleep. They don't really care how they're sleeping. But then in my clinic, I see a lot of children who obviously look sleep deprived, but their parents aren't fully aware. Do you see that as well?
So I think the world is going more horizontal in the
Hmm.
sense that we are sharing far more problems, I would say, with the rest of the world than we would like to. The modern day problem with, especially with the digital exposure that the kids get nowadays,
Hmm.
unavoidably so, because for a lot of kids, their teaching is online nowadays. So a lot of their content comes from devices. So yes, we do see, but I think the way I would put it is, I mean, as a parent, I care how my child sleeps. It's just that I've never thought of it as a health concern. I
Hmm.
never thought of it, it's always sleep like a baby. So we always think that
Okay.
we have sleep issues as adults. Children, I mean, they are so, we all want to sleep like a child, right? So their innocence and their innocence help them sleep better. So even as doctors, we never thought of, a broader population of children at large having a
Mm.
common sleep issue. So definitely sleep issues are common here. However, because there is lack of awareness, even in
Mm.
medical professionals, leave alone the general population, so they go underdiagnosed and unrecognized more often than not.
So, what would be your first kind of advice to a parent to see that to check if their child is sleeping? So let's say, for example, we split up into different age groups. So I myself work with a lot of babies and toddlers, and I'm always saying check for mouth breathing when sleeping, check for snoring. But in the older children, what would you also suggest? And in that age group, from an ENT perspective, what would you be looking for?
So I always like to keep things simple,
Hmm.
So what I would like to ask a parent first is your child really sleeping like a baby? And what do I mean by that? Is it sleeping like a log? Is it sleeping in one position, preferably, chest up, sleeping supine is what we say, on their back?
Mm.
Are they comfortable sleeping in one position, or are they frequently trying to change their positions in the bed?
Mm.
Is the term that I use, is he a restless sleeper, or is he someone who can sleep like a log? So that's typically the ticker, and people or children with sleep apnea would be very restless sleeper. They are not comfortable sleeping on the back, they are not comfortable sleeping on the side. They would try to extend their neck, find a corner, they would want some elevation, they would not be happy with one pillow, they would want to keep their head on the parent's chest. and sleep. So they will pick up some awkward position, and when we start talking with parents, then they recognize, okay, you know what? I thought this is just how things are, but now
Mm,
that you're telling me, I can tell that this is not normal. So that's one trick. Second is I look for I'm not happy with any noise of breathing while sleeping.
mm,
So I'm not happy even if there is a slight but persistent sound. So, what I'm worried about is not that occasional snore which happens when the child is having a bad cold, but
mm,
a child whose snoring essentially is a way of life. The child will snore whether mildly or softly. And I tell the other thing that I tell parents to look for is if the child is snoring, it's a yes and no question. It's not, you know what, my child has got the mildest possible snore. As an
mm,
ENT, I know children should not snore. So let me rephrase that. Children with healthy, open, uncompromised airway should not snore. Even if there is a
mm.
mildest sound of breathing at night, the perfectionist say should not accept even the mildest sound of breathing. Is the way I look at the science behind, obstructed breathing spells. So I hope that answers your question.
No, it's done very well because two of my mentors, Dr. Baxter and Dr. Zagi, who I think you went to Stanford just a
Yes.
year or so after Dr. Zagi or before.
So it was actually a couple of years before,
Okay.
and both me and Dr. Zagi have the same guru. He is Dr. Capasso, Dr. Robson
Yeah.
Capasso out of Stanford. So we
Mm.
both got to learn from the same mentor.
That's amazing because the world needs more ENTs like you and Dr. Zagi. And one thing that when I came into the whole world of airway and breathing and sleeping is that everyone always used to assume that a bit of snoring is normal. And even my patients say, well, he doesn't snore all the time. He snores a bit. And then what I do generally tend to do as well, and following Dr. Zagi's advice, is ask for a couple of minute video of their child sleeping. And then I see exactly what you described. I see the child
Yeah.
restless, moving, sometimes throwing their bum in the air. And I'm looking, thinking, if this child is not getting that rest they need, what could be the consequences, Rahul? What do you think could be the consequences of this lack of sleep?
So actually, it's not rocket science.
Yeah.
It's something that any parent can figure out on their own.
Mm.
So a small practice that I tell parents to do is to just stuff your nostrils with a little bit of a cotton
Hmm.
and try sleeping for 4 days in a row.
Wow.
And try and imagine how they are going to be as an
Yeah.
individual, as a professional, as
Yeah.
a performer, as a colleague on day 5 of that, poor quality sleep.
Mm.
Now you translate that into the child's life where the child has to focus on school, has to be playful, has to have concentration, has to absorb new things every day.
Mm.
See, in a growing child's, I would say, brain and overall personality, each day of fractured sleep or poor sleep adds to their, like an obstacle in their journey. As adults, if we are not able to cope up with 4 days of bad sleep, how do we expect the child to cope up, with months and
Mm.
months of fractured sleep? Is the way I look at it. So once I
Yeah.
tell them to do it themselves, I think it dawns upon them that why the child is behaving in certain way. If the child is very jumpy, if the child is having difficult sitting in one place, the child is very irritable, has anger bouts. I mean, I would not blame the child because the child
Mm.
has actually slept for so many days.
It's so interesting the way you put it that way, because that's one thing I feel currently in the medical system is overlooked with how a child sleeps and how the effect that poor sleep has. Because how I kind of see it is when you're snoring, the body doesn't get a lot of oxygen going through. Children need oxygen to get the reset themselves when they're sleeping. When you're awake, yes, you can more or less compensate, as we say. But I'm going to throw a bit of a curveball here. And this is just me putting my mind together with what I've learned from Dr. Zagi and speaking to yourself and other ENTs. I saw a video the other day on YouTube about, obviously, it's a very drastic example. Okay, so
Mm.
this was it was one of the biggest serial killers in the world, and when they did a
Okay.
study of his brain, they saw that there was parts damage due to hypoxic events. Now, obviously, we don't know his full history. We don't know what can happen, but part of me in my head was like, wait, did they ever check that this child was snoring and could have sleep apnea, and that's why he developed these tendencies? Now, as I mentioned, it's a completely extreme case here, but for someone listening, would this can the effects of snoring and sleep apnea damage a child's brain? If have you seen any cases in your experience, or is this something that we know in theory, or is it possible in practice?
So, good question. So, see what happens in medicine now. We try to find associations between different disorders.
Mm,
So, the example that I give to parents is like diabetes. We know
mm,
that untreated diabetes can damage kidneys, untreated diabetes can damage the heart, can damage the eye, but we will not find every diabetic suffering from all of the problems. We'll have some
true.
diabetics having kidney issues, some diabetics having heart issues, some diabetics having eye issues. So our understanding for something that we have been studying for 150 years, such as
Mm,
diabetes, is still incomplete in terms of we are yet to predict, you know what, this subset of patients will suffer from kidney
mm,
problems, this subset is. So imagine pediatric sleep apnea. Sleep apnea in general is hardly maybe what 4 decades old, the understanding
mm,
around it, and the understanding around pediatric snoring or pediatric sleep apnea, sleep disordered breathing, and interchangeable terms
mm,
is fairly recent. So yes, can sleep apnea impact a child's brain development? I would say yes. Will
mm.
every child suffer from it? Absolutely no.
Yeah.
Will so the other way, if the child is the way I put it is, if the child is susceptible to it, the child will suffer from it. However,
Mm,
I would not go so far to say that, if you don't treat a child who's snoring today, he's likely to become a serial killer at some time in the future. So
yeah.
that is where we have learned it the hard way that we
Mm,
tend to extrapolate a lot of our medical knowledge uh, beyond reasonable means, especially during COVID.
yeah.
So we tried all kinds of hacks for COVID, especially in the first wave.
Hmm.
Uh, and then because we saw so many of those hacks failing so fast, we became wiser by the second wave as to which medicines will work, which interventions will work, and what is not going to work. Now, that timeline is not going to be the same for any other condition because we are not going to have a gazillion people falling down with sleep apnea
Hmm.
in a year and then, so it's an evolving science. What we know for sure that if I get a kid who's jumpy, if I get a kid who's got attention issues, especially if I screen and catch this kid early on by the age of 4 years, 5 years,
Mm,
then there's a good likelihood that once I treat the child's sleep apnea, at least some amount of it will reverse. And by treating, I don't mean surgery alone. I've had
mm,
kids where the parents have noticed a significant change in behavior with just 3 months of medication. Simple allergy
mm,
medications given for 3 months, ensuring the child is having a better sleep than the child was having just 3 months ago. And we see differences. However, the jury is still out there. There is a lot, and unfortunately, there are a lot of Instagram videos also circulating where
mm.
we want some awareness to build up, but they just scare the parents. You know what? If the child
Yeah.
is not going to sleep well, he's going to come back with bad scores, and he's going to have a low IQ,
Yeah.
and it's not true for every children.
Hmm.
Susceptibility, we know 1 out of 4 children having sleep apnea or sleep disordered breathing are at risk of developing attention issues or hyperactivity. But that's just 1 out of 4. So it's
Yeah.
not 0 out of 4, it's not 4 out of 4, it's 1 out of 4. Roughly about 25 to 30% of the kids with sleep apnea, and that is what the research tells us so far.
Because that's a good point you raised, because I do get a lot of patients myself, and the parents have been given a ADHD or diagnosis, which I'm not license to kind of agree or disagree
Sure.
with. But what I can see is this child constantly breathes through their mouth. And from what my side, I kind of see from a dental point of view, obviously, if we mouth breathe, we activate the sympathetic or the fight or flight nervous system a lot more
Right.
than if we nasal breathe. And then I also do see quite a high link between, obviously, enlarged tonsils, narrow palates, etc. on that
Yes.
side. And then I'm thinking to myself, I'm like, well, if we've got these tonsils which are blocking the airway, will it be easy for them to breathe or will it be harder? And then I'm sending these patients to an ENT to say, well, look, let's try and make this child's breathing easier and then see how this child evolves. But one thing I do get a bit of backlash from is size of tonsils, when to treat. I kind of see it from my very simple point of view, like I'm not you, I'm not Dr. Zagi. If we've got enlarged tonsils, they're probably blocking the airway and that child's struggling to breathe when sleeping, as I believe. But then as an ENT, obviously speaking to other people, when would you feel is appropriate, or how do you treat like the patient coming into your practice with enlarged tonsils? And I'm talking usually for the lay people there, enlarged tonsils is where you get the patient to open their mouth and you see these two little red balls there. They can either be kissing, they can either be a bit of space on that side. But yeah, back over to you, Rahul.
So the way I tell parents is, in fact, I tell them to focus on the symptom.
Hmm.
It may be enlarged tonsils, it may be enlarged adenoids, it may be the obesity of the child which is causing this, it may be badly optimized allergies. These
Yeah.
are primarily the four common reasons why a child snores. Like I
Hmm.
said, I'm not happy, especially if I get a child who is still, not even 10 or 12 years old
Hmm.
and having the slightest amount of sound while breathing at night.
Yeah.
So, I mean, I'm not saying that I should treat and operate every child with that, but I know that if there is sound of breathing, there is some obstruction.
Hmm.
Breathing should be a silent process. Most kids will have a noiseless breathing at night. Now, when there is a sound of breathing, we need to look for the location or the site of obstruction. And the most common site of obstruction is enlarged adenoids, which are hidden from plain sight. They are
Hmm.
like tonsil tissues right at the back of the nose. And enlarged tonsils come, I would say, in 70% of the kids as a package. So the typical
Yeah.
child that I see whose mouth breathing is snoring will likely to have large adenoids with or without large tonsils. So that's and then the child may have varying degree of enlargement. Sometimes the tonsils may be larger than the adenoids may be larger than the tonsils. So the problem is not with adenoids or tonsils alone. The problem
Hmm.
is with the fact that they are actually obstructing the airway. If there were
Yeah.
tissues anywhere else in the body and if they were enlarging, we get lymph nodes all over the neck.
Hmm.
These are lymph nodes situated lower down, upper, and
Yeah.
every time that anybody develops a bad throat infection, a lot of these lymph nodes may enlarge, but they don't encroach upon the airway.
Yeah.
My worry is whenever I see a symptomatic child, and by symptoms I mean a child I just tell parents to focus on two things. Focus
Hmm.
on persistent mouth breathing. If the child has to open his mouth to breathe while watching television, not while the child is at his peak exercise performance. No, not that's not the time to adjust.
Yeah.
You judge when the child is watching television, sitting idly, reading a book, if the child just and
Hmm.
you don't need a wide open mouth. You just need the lips to be apart. See, as adults, your natural position, if I may say so, is when your lips are sealed. You are not programmed to keep the lips apart.
Yeah.
Breathing through the mouth needs 5 times more energy to maintain the same oxygen supply as breathing through the
Wow.
nose. So it's not an energy efficient process.
Hmm.
So you want to just relieve, and it's a breathing process, right? It's something that child is going to do every minute for the rest of his life. So you want the
Hmm.
child to be able to comfortably breathe. So that's the assessment. I hope that answers your question. So if there is persistent mouth breathing,
Hmm.
persistent snoring, we look for an obstruction. And typically the obstruction is adenoids and or tonsils, but we may have some allergy issues along with it. And obesity is also catching up, especially I would say when I see a teenage
Hmm.
kid to impact the breathing also alongside that. But in India, childhood obesity, yes, it's becoming a problem, but
Mm.
still, it's probably 1 out of 10 kids that I see. 9 out of 10 kids are poorly optimized allergies and adenoids.
Yes, and I myself suffered from very bad allergies as a child and was mouth breathing, and
Sure.
uh, which kind of brings me to my next point, which is, as personally, this is my obviously opinion, what I've kind of seen with my studies and my patients. Now, I see most it's kind of a chicken and egg question. What came first? So, did the enlarged tonsils and adenoids cause the mouth breathing, or did the mouth breathing cause the enlarged tonsils and adenoids? And that's one question which I feel I spoke to, for example, another pediatric dentist that treats babies, and he says at this point, well, if the baby's constantly mouth breathing, the air needs to be filtered, heated, goes down to lungs, that baby will develop enlarged tonsils later in life. But from an ENT, in your opinion, what do you feel is the cause?
So, good question. And I think you will not get one straight answer that
Mm,
everybody will agree upon. There are theories and there are going to be theories. So, here's how I have understood, the current level of understanding and what I see in
mm,
patients. There is a definite genetic tendency to
mm,
develop large adenoids and large tonsils. Um, Typically, if I'm seeing a child, there is a very high likelihood that either of the parent is snoring.
yeah.
Either of the parent is likely to have some degree of diagnosed, maybe undiagnosed sleep apnea.
Mm,
So there is a definite genetic tendency to develop large amounts of this. Now, for the child, if a 1 day old child is not programmed to mouth breathing
mm.
is an acquired habit. Now, why did the child acquire
Wise
that
words.
habit over a period of time? Is because he or she wasn't getting enough oxygen through the nose in the first place. And that is
Mm,
why if you're aware of something called as a complete choanal atresia, which is like a membrane that, certain newborn babies may have at the back of the nose, where they are not able to breathe at all. And that is a medical emergency because a 1 day old child does not know how to breathe through the mouth naturally. You have to put in an airway and do an emergency procedure to break that membrane so that the child
mm,
is able to breathe through the nose. So we know that there is a genetic predisposition. We know that nasal obstruction is the primary cause for mouth breathing. Now, whether the nasal obstruction is because of allergies or adenoids or some other pollutant in the atmosphere, I mean, we can all debate, but the
yeah.
nasal obstruction should be the first event that leads to mouth breathing. And maybe mouth breathing can cause enlarged tonsils, but once they are enlarged, ignoring them does not make sense.
Mm,
Thinking that I will just do adenoid surgery, I will do some dental procedure so that the child goes back to nasal breathing, and then slowly over a period of time, the tonsils will shrink in size and come back to normalcy. I'm not a very strong believer in that thought process. If I get a child who's snoring, who's got gigantic tonsils and enlarged adenoids, I need to treat those so that I give the child the best chance to overcome this problem. Half
mm,
treatment is not going to get the child anywhere. I hope that answers your question.
mm,
That, I mean, regardless of what comes first,
yeah.
I have to treat everything. The dentist has to treat the child, the ENT has to treat the child.
Yeah.
So, I mean, for me, it doesn't matter what caused the problem because this is a common question that parents ask. Doctor, what do you think caused the problem? I am like,
Mm,
whatever the reason may be, we have to treat it. The treatment will
yes.
not differ, the algorithm will not differ. But logistically speaking, I feel there is a genetic predisposition. Most
Hmm.
kids will have a parent who's snoring. I'm dead certain on this. I would say that number will be closer to 80% or something like that. And second is once a child has developed it, you have to treat whatever is obstructing, whether it is adenoids, tonsils, allergies, whether it is a contracted maxilla, whether it is a tongue tie contributing to the entire thing.
Hmm.
You have to give your best shot and treat everything at the first go, not treat half and then hope some magic will happen. And it doesn't work that way.
No, it's great words, and I love the fact that you mentioned retruded maxilla and tongue tie, because that brings us on to my next question, which is how, as an ENT, how do you feel structure influences? Because there's another big debate that we always have is structure versus function. Now,
Sure.
what I kind of people like to be purists and go into two camps. One will say that function is important, structure comes secondary. Some say structure is important, function comes secondary. Now, I kind of believe it's a yin and yang circle. You've got to have a good function leads to good structure, but good structure also leads back into good function as well. And the amount I would say, like we're talking about genetics on this side, and we talk about narrow palates, etc., which I do believe there is a very small genetic component, but I do think that as we, like you said, most parents these days come in with really narrow maxillas, which also makes, in my eyes, the nasal passages quite narrow. And then
Absolutely.
also the amount of people coming in to see me with tongue ties is very high as well, because that's also another reason they come in on that way. But how do you feel as an ENT that if you've got a patient who's got a retruded maxilla, high palate, the mandible's really far back, they've got a tongue tie as well, let's just throw that all in there. How do you approach this patient? Is it important collaboration in your eyes, or do you feel that we should be very defensive of what we do first in that way?
No, so it all depends upon at what age group I'm seeing the child,
Mm-hmm.
and that decides the trajectory. Our approach for a 4-year-old can't be the same that we take for a 14-year-old or a 24-year-old or even a 34-year-old. So we can't
Yeah.
have one template that will work for every children. Now, at the outset, the basic premise is the way I work and the team of doctors that I work, and I'm very fortunate to have, great pediatric dentists who think like the way I do. We
Mm-hmm.
want the best for the child. Now we look at, are we able to achieve just with good medical therapy? Say, let's make it challenging. Now, if I get someone with grade 3 or grade 4 enlargement, which is as large as it can get for tonsils and
Mm-hmm.
adenoids, I think there is no confusion. You have to treat these things first and then take over the secondary impact, which is on the jaw structure. And you may choose to, I mean, the way we work out is if I'm going to anyway operate a child for sleep apnea, and if the child has got a bad tongue tie, then I'm very happy releasing the tongue tie myself in that one anesthesia.
Mm-hmm.
However, if I feel I get a borderline kids, let's make things even simpler. I get a child with pure allergies, does not have large tonsils, does not have large adenoids, but has got bad allergies which are causing a nose block, causing mouth breathing, and causing all the facial changes that we are worried about in a child with, sleep apnea. So in that patient, I would not rush into surgery for adenoid and tonsils. I would focus maximally on treating the allergies first. And then, you know what, my pediatric dentist will be very happy to take care of the tongue tie because
Mm-hmm.
the child is going to spend more time with them than they're going to spend with me.
Yeah.
Again, the debate, and like how in academic circles now we like debates, but
Yeah.
sometimes I mean, being a general ENT in private practice, I always feel that debates are good, but I want to know what is the message that I want to give it to the ENT practitioner out there in the community when he's facing patients.
Mm.
So, I mean, when you were talking about structure and function, the example that came to my mind is, do you want a child who's studious, very sincere, going to a not so good school and then expecting to perform? Or do you want a child who's not sincere but going to the best school and expected to
Mm.
perform? You are like, this is a stupid debate. I want my child to be studious
Yeah.
and going to the best school. I mean, where is the debate? So I want the child to have good structure and good function. Now, if that involves operating the child and then spending 2 years with the dentist, I'm sorry, that is what it is going to take.
Mm.
So the child is already 10, 12, 14 years old, and the child you know, had a mouth breathing issue over a decade of his life, and that is not going to just change with the surgery. So I mean, I think of it, if it was my child, I want my child to have the best facial architecture and have the best breathing habit
Mm.
to be able to achieve their full potential. Because I know even if either of them is not good, if if the school is not good, my child is not going to realize his full potential. And if
Yeah.
my child is not studious, the best school is not going to help my child becoming, a better professional or a better individual. I want both. So I want good structure. I want good function. And it's a judgment call. And that is why it's teamwork always.
Mm.
Even if I think, I get a 4-year-old and I think, what, there are no changes that have set in as yet. I still kind of introduce the idea to the parent that likelihood is high that I will operate and the child should revert back. However, keep in mind that at some point in future, maybe when the child is 7, 8, 9, 10, I may ask you if I'm not happy to meet a pediatric dentist then. However, if I'm seeing someone who's 8 years old, 10 years old, 20-year-old, my discussion starts with the fact that this is going to be a team approach. I know that your child will need both. Your child will need an ENT and an airway focused dentist. Both of us will do an initial assessment and then we will come back to you with a plan. Typically, if I want to generalize now coming to the templating, how do I normally template it? It is going to be the ENT first, who will remove any possible obstructions, maybe tonsils, maybe adenoids, maybe large turbinates when I'm dealing with teenage, maybe a tongue tie. First, I'm going to give the dentist a completely wide open airway. I'm not going to give
Yeah.
the dentist a compromised airway, which is somewhat minimally optimized with medications, and then expect whatever orthodontic treatment that they are doing, whatever myofunctional treatment that they are doing to create some magical outcome. Because I've
Okay.
not treated the root cause here. So I hope, that gives the answer as to how does one approach this problem.
Beautiful way of putting it about the child being studious and going to a bad school. I'm going to definitely use that one in the debates when they get asked structure or function, because like you said, I'm on both sides. I said it needs to be in harmony, but I think we get, like you said, in the medical community, people get very picky about, oh no, this is a structure issue, this is a functional issue. And I said, look, this unfortunately most of the time it is both, and you
It
have to
is.
end up treating on that side. Now, you did
So
mention
just
before,
just to put just to put
yeah.
a rider there or like a small asterisk mark there.
Mm,
Sorry to cut you out.
no.
Syndromic children are different. So
Yes.
if I get a child with Down syndrome, if I get a child who's having syndromic issues, neuromuscular weakness, those are different kids. And it's a spectrum in
Yeah.
the sense that I may get a seemingly healthy child. And if I think the structure is otherwise okay, like I said, the child does not have large tonsils, the child does not have large adenoids, the child does not have enlarged turbinates. In fact, recently I had treated a dentist child for that matter, where the structure
Mhm.
looked reasonably okay and it seemed like a muscle tone issue. And we just worked on it with some medical management and we got. But if I get someone with a compromised structure to begin with,
Mm.
um, out of a 4-lane highway, I'm going to block 3 lanes and then I'm going to expect people to drive well with discipline and have no traffic jams in place. That's an unrealistic expectation, right? I need to
Yeah.
fix the infrastructure first so that I allow the driving discipline to come into play.
It's funny you mentioned driving discipline, because that just took me back to India, where there's with all due respect, there's lanes, but there's everyone kind of goes their own way.
So the driving example actually hits home every time when I talk to the
Yeah.
parent. I'm like, you know what? You want people to drive well, but you
Mm.
got this bad bottlenecks, bad roads happening.
Yeah.
How is that? Because the guy is not going to drive through a pothole. He's going
Yeah.
to change lanes and he is going to come in. So that's the example that I give. If I've
Yeah.
got an obstructed airway, how do I expect, just tell the child to breathe through the nose.
Yeah.
But boss, the child has got like an 80% obstruction. How do you expect the
Yeah.
child to breathe through an obstructed nose? So fix the infrastructure. If
Yeah.
you feel that the infrastructure is reasonably okay, then focus on the function. So, if the structural assessment comes first, and
Mm.
if the structure is all okay, then focusing on function makes sense. If the structure is compromised, then how much ever I focus on the function, it's not going to help me. But my story doesn't end with just focusing on the structure. I
Yeah.
need to realize that functional improvement is equally important.
No, definitely. I work a lot with myofunctional therapists as well and ENTs, and I think definitely being a big team where you all kind of speak the same language together. So I get a lot of times where before when I first started the airway journey, I would send a patient to the ENT. The ENT would say, "Don't worry, they'll grow out of it." And I'll say, "Well, they're kind of grade 4 at this point. I would want something done. The child has ADHD, running around like extremely sympathetic overload on that side." And that's where I was looking, and I did more studies, found my community, and now I'm happy to say that we do have quite a few more ENTs who do like to sit down and have a conversation. We say, "Well, look, what do you see from your side?" And I'm saying, "Well, I see that these tonsils are not helping anyway on our side, and even if you look at expanding or changing the oral cavity, but they're still mouth breathing, you're going to get a relapse of what you were trying to correct anyway." So in essence, it's all of us working together is fantastic. What I was saying before is you mentioned that a lot of parents probably snore or have sleep apnea. Now, one thing I really enjoyed when I was in Amritsar was the talk about the metabolic effects of sleep apnea. Could you tell us how you feel that like sleep apnea can affect, let's say, just so how we work is very holistically, and I believe on giving parents all the information. So I say, look, your child can either compensate or not, but these are possible effects that you might see in the future. Just so you're aware as a parent, or to inform people that these are the effects of snoring on the metabolism. Could you talk a bit about the metabolic effects of sleep apnea, in your opinion?
So, see, so the one thing that happens in
Hmm.
sleep apnea that we know is we get fragmented sleep.
Yeah.
Okay. You don't get single stretch of sleep,
Hmm.
be it a child or an adult, you get fragmented sleep. Now, if we don't get a continuous stretch of sleep, we don't spend enough time. The child does not spend enough time in deeper stages of sleep, or what we
Mm.
call as a slow wave sleep. Also, the child does not spend time in what we call as REM sleep, which is very
Mm.
important for your neurocognitive development. Now, take these out, and then it is very easy to decipher how the child would be the next day. The younger kids will be more jumpy, and they will have predominantly impact on their neurocognitive metabolism.
Hmm.
The older kids will be more sleepier.
Mm.
So the neural outcomes are very easy to decipher that anybody with a fractured, fragmented sleep over a period of weeks, months, maybe years, a lot of times, how their brain is going to behave. It is going to slow down. It may not focus as well. It may not develop as well. The other thing that we know for certain is the brain reduces the production of what we call as a growth hormone.
Yeah.
So typically, a child who has undergone a tonsil adenoid surgery within 6 months to a year will have a growth spurt. And the thought process here is we normalize their growth and development by ensuring that they get normal growth hormone production. So that's one part of the growth and development in terms of the child. Now, the other thing that is happening is because of repetitive obstruction, there is a wild swing in their oxygen levels in the blood.
Mm.
Like somebody is choking them frequently. There is a dip in the oxygen level, and the person is like waking with a gasp. Now, this is very evident in adults.
Yeah.
However, in children, because their body is very sensitive to even minor dips in oxygen, generally they don't face wild swings in their oxygen level. However, there is enough and more research to show that even in kids, untreated sleep apnea puts the kid at a higher risk of cardiac side effects. Remember, which
Mm.
system is responsible for delivering oxygen all over the body? It is your heart.
Yeah.
Now, if the heart does not have a steady supply of oxygen, the heart does not know at what rate does it need to beat, at what
Mm.
pressure it needs to beat to ensure optimal supply. You are reducing the supply, then you are increasing the supply, and then you are varying it.
Yeah.
So that is the time we get increased sympathetic tone. And again, there is a good amount of research to show that a lot of kids with proven sleep apnea, when
Mm.
an echocardiography, it's an ultrasound of the heart, was done, they had some minor weaknesses in the heart, which completely reversed within 6 months of their tonsil and adenoid operation.
Wow.
So we may think that this minor component may be quote unquote normal, but we
Mm.
will not know what is normal till the child actually breathes well and sleeps well. So these are the two areas, the brain and the heart, which have been studied extensively. Beyond that, there are some studies to show that even your glucose metabolism
Mm.
changes depending upon whether you've got a good breathing or not at night. I feel people find it easier, especially in adults. A lot of research is there out in the adults. With children, we are just about reaching there. But in adults, we know, like, if I want someone to lose weight, I
Yeah.
don't think it will be easy for that person to lose weight till I put that person, I'm assuming that person is having sleep apnea. If I put that person on PAP therapy,
Yeah.
once the person goes on a CPAP, he sleeps better, he wakes up fresher, the system is well rested, the sympathetic overdrive has kind of blunted now. And now, if I want the person to lose weight, then it is far easier for the person to adhere to a diet and an exercise routine
Yeah.
than a person who's like untreated sleep apnea. Even if I'm thinking, like, given these patients the newer drugs that are come up for weight loss, I feel they'll help, or they'll be helped a lot more if you treat sleep apnea alongside any of the measures that you're going to do weight loss. So three systems, that primarily the heart, the brain, and your overall energy metabolism. Last point is something. So I had an 18-year-old girl
Hmm.
who used to snore, and restless sleep, the works. But one thing that the parents thought was not related to this was bedwetting. I had an 18-year-old girl
Mm.
who could not go for sleepovers because she had bedwetting issues. And that is something which is frequently missed. So if the child is got bedwetting, especially what we call as secondary bedwetting, meaning for the first few years of life, the child had good control. Say the child developed good control by the age of 2 or 3, but then by the age of 8, lost control again.
Mm.
He was not bedwetting between the age of 3 and 6, and after the age of 6.5, 7, he started bedwetting again. That is also a red flag. So that is something that I will actively look out for, because
Yeah.
what sleep apnea does is the fragmented sleep does not allow adequate ADH, or antidiuretic hormone production, and
Mm.
that leads to increased urine production at night and bedwetting. So these are the various ways at which um, the sleep apnea may impact the child's growth and development, metabolism, if you may say so. But as and when we are getting more research, I think we'll get to know that anything other than this also is likely to get benefit by treating sleep apnea, because you're just allowing more oxygen to flow in the body in a more consistent manner. Just that.
You know what? You've said it so well. And I think the people listening will be so happy to know that these are the effects that we can probably see, because I see it in a lot of my practice as well, that some of the adult patients I have, they, especially a lot of people who do this biohacking, they look at their food, they don't actually look at their sleep as much. They just think, okay, I'm sleeping X amount of hours. But then I said, well, how are you sleeping those hours? How are you breathing? And then they suddenly go and get a sleep study, and they find out, well, actually they've been battling with sleep apnea this whole time. And then all of a sudden they get that kind of treated. They start losing weight a lot better, and they feel a lot better. And it's when I do talk to a lot of patients who like biohacking, I say, just always remember that sleep is probably one of the biggest cornerstones on that side. And they're very reluctant to see generally doctors and stuff. But I do advise them, I said, a functional ENT like yourself, or find your community, look online, see an ENT or doctor who can actually work with you and get you the best results, so you and your family are in peak state a lot. Now, I am cautious of the time because I know you run a very busy practice and I'm keeping you away from patients. But what would you, so just the final few messages for our parents and any practitioners out there, what would your takeaway message be in summary?
So my takeaway message will be both for parents and I would say even for pediatricians who get to hear this conversation, this podcast, will be screen or look out for a child who's primarily having noisy breathing at night. You may not
Mm,
call it a snore. You may not call. If a child is frankly snoring, please don't ignore. So don't ignore the snore. If that's the only message that if you take away from this conversation, I'm happy. I mean, I think our objective has been achieved. Along with that, look for mouth breathing.
mhm,
Okay. Sometimes you may not get snoring along with mouth breathing, but if there is persistent snoring and persistent mouth breathing, I would say consult uh, a close by ENT physician. Uh, Hopefully, that ENT doctor is sleep trained and sleep oriented. If not, then you can raise your concerns. And I think the awareness is coming. I mean, 10 years ago, it was
mm,
difficult to convince a lot of senior ENT practitioners that we need to be more aggressive and more proactive in identifying this. But now I think enough and more work has been done. Enough and more papers have been published, research has been published to create that awareness. So these are the two things. Other things that can happen, like we discussed, if somebody is bedwetting, having a
mhm.
restless sleep, and more importantly, we didn't talk about grinding of teeth. So bruxism
Yeah.
is a very important symptom, especially in younger children. In
Mm,
adults, bruxism is a very different kind of a beast, I would say. There are other factors that may impact. But in children, definitely look for grinding of teeth at night. And you'll be surprised is when you treat their airway, the grinding almost always goes away almost instantaneously, I would say within weeks of treatment. So that's very gratifying. I would not like to tell too many things and confuse our listeners. So I would say snoring, mouth breathing, grinding, restless sleep, and perhaps bedwetting. If you find any of these or all of this, please approach a sleep trained pediatrician or an ENT for further evaluation.
No, thank you. And yes, you are right. Grinding teeth is a big sign in my eyes, and I that's one of the red flags that I always see with pediatric sleep disorder breathing is you'll see a 4-year-old who's almost ground his teeth down to little stubs. And
Yes.
this is where I get upset with some of my colleagues when they say, "Oh, it's fine. That's just temporarily." I said, "We do have a bit of physiological grinding when the teeth start coming in as you're getting used to the occlusion, how they're sitting. But if I'm just going to evaluate that point further. If you do see no, and the teeth have got no spaces together in the pediatric dentition, so these teeth are very straight, very nice and perfect, almost but ground down. That's also a sign that there's not enough space in the oral cavity in the structure as well. Just adding your point there, Rahul. But once again, honestly, it's been such a pleasure to have you. And look, I hope to always see you anytime I come to India and all these other conferences. But you're also welcome to come to the UK. And when we do run conferences, we will keep you in mind as well on that side. But thank you so much for your time.
My pleasure. My pleasure. Thanks for making me a part of this wonderful conversation.
You're more than welcome.